When I was in middle school, I assisted my father, an anesthesiologist and pain managed physician in New London, with his PowerPoint presentations. They usually went something like this. Sumeet, begin by describing the signs and symptoms of malignant hyperthermia, proceed on to clinical symptoms, and finish off with treatments. I was 12 years old at the time, and my father was expecting me to come up with everything about malignant hyperthermia. All right, I was very humbled, and to this day I greatly appreciate his overestimation of my abilities, and he could definitely have found a much better presentation maker. However, helping my father with his PowerPoint presentations gave me an outlet into medicine and really showed me this is what the field is. So I decided one summer, maybe I'll go and volunteer in the hospital, see what it's like. So I went to the hospital, and to my surprise, I actually really enjoyed it, and I went back for 2 more summers. It was during my final summer volunteering in the hospital, where I volunteered in a department called same-day surgery. This is where patients go before they actually have to go into surgery, right? So my job was quite simple, Here I am walking around the rooms asking patients, do you want a warm blanket? Do you want a towel? How can I help? Are you ready for your surgery? Making them comfortable, because surgery is a very scary experience for some people. So I was trying to make them as comfortable as they could be. It was during one of these rounds where I was able to observe physicians and nurses huddled together. They were discussing the active care of a patient, putting all their minds and resources together. No arguing, no fighting. It's like a well-oiled machine of humans working together at one simple task, healing the patient. I was amazed to see that. And that day I realized I want to go into this field. I want to be a part of that healthcare team. I want to see tangible improvement in a patient's life from point A to point B. So I worked towards that path. To immerse myself more in the field, I became an EMT, an emergency medical technician. These are the individuals that respond to 911 medical calls. And so when I became an EMT, I volunteered at a fire station called Waterford Ambulance. That's in southeastern Connecticut. And it was wonderful. When the tones drop in the firehouse, when the lights and sirens in the ambulance, so much adrenaline and exhilaration. It was wonderful. I loved it. And my favorite part was when you approached a patient, you could see the smile on their face. They were finally happy to see somebody there to take care of them. It was wonderful, and I couldn't have asked for anything better. Now, it might seem to you that I'm reciting my resume right now, and to be frank, maybe I am. But there's a reason behind it. I want to show you what most people see in medicine when they are first exposed to the field. The glory, the dramatization. Think about the TV shows you've seen on medicine. ER Doctor, for example, House MD. All the glorification, all the treatment modalities, everything going on at once, the lights, the bright cameras, everything works out in the end. It's beautiful, right? It is on TV show. I was exposed to the actual reality of medicine during one of my EMT calls last summer. During this call, the tones dropped as they usually do. It was about 5 p.m. And the dispatcher always says after the tones drop what the call is. The specific dispatcher said, 50-year-old female, wrist slashed, active bleeding. Looking back, I realized most of my colleagues knew what had gone on. A glazed look went over their eyes. I, at the time, was quite naive. I didn't know what was going on. I thought somebody injured themselves, cut their wrist by accident, to bleeding. Went in an ambulance. We sent everybody to these kind of calls because it can be serious. So ambulances went, fire trucks went, the whole game. So we show up to the scene. We see a 50-year-old female on the ground. Obviously, wrists are slashed. And thankfully, the bleeding had stopped by the time we got there. So all we could really do was load her up in the ambulance and take her to the nearest hospital. Before I got on the ambulance to go to the hospital, so still at the scene, there was a police officer there. And the police officer told me she had taken a steak knife, heated it up, and slashed her wrist, cutting into her skin. It's pretty serious, right? So I was taken aback by that for a moment. I had never expected that to happen. I thought it was an accidental injury, right? Nothing as serious as slashing wrist intentionally. It was my first exposure to a call like this. That was the hardest ambulance ride I've ever had to this day, probably because it was my first. So I got on the ambulance, and I was frozen for a few minutes. I mean, what do you say to somebody who's just tried to commit suicide? You don't learn that in class. I did the best I could. I asked her what was hurting, what I could do to help. What can I do to make sure that I can tell the ED so they know, the emergency department, so they know what to expect? So I tried my best. I did the best I could with what I knew. The entire ambulance ride, she was crying, and all she could say was, I just want it all to be over. I just want it all to be over. She later learned that she was referring to a car crash that happened decades earlier. And this car crash affected her ability with her family. It impacted that relationship. And this car crash also impacted her nervous system, so she couldn't control herself well anymore. So she felt herself getting distance from her family and her friends. Reported the potential suicide to the emergency department. They took her, and I went home. I was shocked, really shocked. And I talked to my EMT colleagues about it, and they're like, yeah, we see these calls every now and then. And I talked to my dad about it, the physician. He works in the hospital. He sees this thing. And he told me, he's like, it's part of medicine. It's got to grow up and move on. I was like, okay, grow up and move on. So that's what I did. I applied to college, came here to UConn, began my pre-medical studies, had a wonderful time. First semester was a breeze, loved college life. UConn's great, thankful for all the opportunities. But then I thought it was too easy. So I decided to take 20 plus credits for the next 3 semesters. Decided to enroll in countless activities. Why? Because I thought that's what pre-medical students had to do. I talked to all my pre-medical students' friends, and all they said was, yeah, pre-med life is hard. And since I was having an easy time, I thought, oh, I better catch up. So I caught up, and I would argue I caught up a little too much. Physically and mentally, I could feel myself getting very exhausted. Oftentimes, it was hard to even talk to a friend because I was so low on sleep. So it was very hard. And then I began to ask myself, what's really going on? So I talked to my friends, and still the same thing. They kept saying, it's the pre-med life, man. We've all been there. We have to go through it. So I began researching this topic a little more. I began asking myself, is this really what this is all about? Does this really have to be this way? So I began doing a little bit of my own research on mental health in medicine and mental health overall, and this is what I found. And this pertains to medicine in particular. Take a look at this graph for a second. This is physicians reporting burnout in the United States. 44% of physicians report burnout. 44%, that's nearly half of the physicians in this country. Physicians spend 10 years, on average, maybe a little less, a little bit more, of their life training. Thousands and thousands of dollars and hours. And this is the result. 44% burnout. 300 to 400 physicians commit suicide a year. That's one physician a day killing themselves. And I was like, that's more than double the rate of the general population. And I was taken aback by this. How is nobody addressing this? It's ridiculous. The percent of medical students with depressive signs and symptoms, 1 in 4. 1 in 4. If an average medical student class is about 100 entering kids, that's 25 kids expressing depressive signs and symptoms. Percent of pre-meds with stress pretty much all the time, 26%, a little bit more than 1 reporter. I was shocked with all these statistics, completely shocked. And then the COVID-19 pandemic came around. And things got even worse, unfortunately. For not only for us as medical professionals, for the general population in general. You can see in this graph right here, on the left is what happened during COVID. Percent of adults reporting symptoms of anxiety and depressive disorder in January 2021, 40%. Up here, in January to June of 2019, only 11%. And that's the general population. So COVID-19 had a detrimental impact to the health and well-being of so many individuals. And obviously, I'm sure you've heard about that in the news. What I noticed, though, was when I was serving as an EMT, in the beginning, I mentioned how nice it was, right? Going on those calls, responding, seeing people smiling. But even among my colleagues who had done this for so many years, during the pandemic, it was much harder. It was much harder to be efficient. It was much harder to show that same compassion. We started experiencing compassion fatigue. This is when that stress, that anxiety we feel in the field, we bring it home. Maybe it was overworked hours. We were seeing double the patients we were normally seeing. Maybe it was just the fear of bringing the virus home to our families. Whatever it was, this was taking a toll on our health negatively across the country. I became a COVID-19 vaccinator. I wanted to see this pandemic end. Helped out the Pratt & Whitney field out in East Hartford. Great experience. I loved it. The fact was that we were overworked there too, working long, long hours to try to achieve vaccinations of about 2,000 patients a day. We hit that goal, undoubtedly. It was hard, undoubtedly, but we got there at the result of our well-being and mental health. So I began to ask myself, okay, what's really going on here? I asked myself, is there anything that we can do? Right? What's actually going on? Some of us were able to make it out of this struggle. Others, unfortunately, were not. I'll share one story with you. Dr. Breen. She was a New York City emergency department physician. She committed suicide in the height of the pandemic. I believe it was in April. The reason she committed suicide, according to her family, she didn't leave a note, but she committed suicide according to her family because she was stressed out of the number of patients that she just could not help. Something out of our control was now affecting us as healthcare workers. It was staggering and saddening. But then, as time went on, I began to wonder, what about treatment options, right? If there is so much of an emphasis on mental health in medicine, on improving the lives of others, surely someone is taking care of us, right? And indeed, don't get me wrong, there are resources for medical professionals, for EMTs, for medical students, even for pre-med students, right? The problem is no one's using them, right? 16% of medical students who need psychiatric treatment seek it. 16%. That's almost no one, guys. So what's going on? What is the big issue? Why aren't people seeking psychiatric treatment? Well, let's talk about it for a sec. A couple of reasons. Number one, time. Medical students are overworked. They barely have time to get all their studies done. They're sleeping not many hours a night. You think they have time to go and see a psychiatrist? Probably not. They don't make the time for that. Stigmatization in healthcare. It's a big thing. Studies show that medical licensing boards will actually screen you based on your mental health sometimes. And there's that fear. If I have a mental health issue, how will med school see me? How will residency see me? How will my future patients see me? Physicians will often pre-sign pads for themselves. Physicians will often pay out of pocket for medication. Physicians might sometimes even use false identities to avoid getting prescription medication from insurance companies so it doesn't go on their record. That's how serious this problem is. And nobody's addressing it. So what do we do? Thankfully, there are organizations out there. I am fortunate enough to be part of an organization, as Susika mentioned, called Medical Minds Matter. Medical Minds Matter is a national nonprofit organization started last year with the intention of raising awareness about the issues I just mentioned. We do this at local institutions, at the undergraduate medical school level. We try to host workshops. We try to show students what the issues really are, how to seek treatment if you can, and how to become a positive advocate for mental health in medicine. It's great to see other institutions as well taking similar steps, other organizations taking similar steps. But I still think that more needs to be done. It's great, in fact, that I'm standing up here today, willing to give you this talk as a pre-med student, talking about my own struggles. That is also a wonderful step. But what needs to be done, truly, is a change in how we view mental health. We shouldn't view it as a problem, per se. We should view it as something that is normal, that is expected, and something that you should be fine talking to someone about. More importantly, we should advocate for those individuals who take a rise, those individuals in society who we look up to, who bring mental health issues to the forefront. Take Simone Biles, for instance, one of the elite gymnasts in the world, excusing herself from the largest international competition, the Olympics, to take care of her mental health. Really showed the world, this is real. It happens. What can we do? What can we do about it? I think that's a great first step, and I really appreciated her for that. I want to turn your attention to Maslow's hierarchy of needs. In the 1900s, Abraham Maslow, a psychologist, he proposed this hierarchy of needs to showcase basically how individuals progress in terms of what needs they need. At the bottom here, we have the basic needs. Physiological needs of food, warmth, water, and rest. Easy. Psychological needs. As individuals progress and mature, they look into safety needs, belongingness, and love needs. Looking at intimate relationships, security, safety, looking for that compassion and those relationships. We move on to feelings of accomplishment and prestige as you age. And finally, we finish up here with self-fulfillment needs, self-actualization, achieving one's full potential, including those creative activities. Medical professionals often are praised up here. Think of all the stories you read. Oh, doctors saved thousands of lives during the COVID-19 pandemic. Harrowing stories of nurses. New York City fire trucks and ambulances give a parade for all these nurses and healthcare workers. How many of these healthcare workers are actually achieving right here? The physiological needs. How many of them are caring about their sleep, their mental health, their well-being? It's critical for us to ensure that individuals know at all levels that we gotta promote down here before we start promoting things up here. We gotta promote these basic needs before we start trying to achieve these self-fulfillment needs. Because the courage to persist, the ability to keep going in the face of adversity, occurs best when we can address Maslow's hierarchy of needs from the bottom to the top as it was intended. Thank you.